Good afternoon, everybody, and thank you for having me for this session. As we know, cancer treatment is a multidisciplinary treatment with surgery, chemotherapy, and radiotherapy. However, since 80% of the cancer patients in India present at an advanced stage, palliative care should be integrated into active cancer care and not reserved for end-of-life care only. Palliative care and pain. Can you hear me? Sorry, can you hear me?
Yes, ma'am, we can hear you. Yes.
Can you hear me?
Yes,
Loud
ma'am.
and clear.
Okay, sorry. So palliative care and pain management have largely been ignored because the measures of health outcome have been cure and extension of life. Caregiving interventions that alleviate pain and severe health-related suffering and increase the dignity at the end of life, which are the essential features of palliative care, have been grossly neglected. Also, cancer does not affect an individual, but the entire family. And support to caregivers and communication are also important aspects of palliative care. So we would, can I have the next slide, please? So in this panel, we've got Dr. Navin. The other two panelists are also there. Can I have the, Dr. Navin?
Yes, ma'am.
Dr. Jayarajan?
Yes, I'm here.
And Dr. Prakash Fernandes.
Yeah, good afternoon.
Dr. Navin is from KIMS Manipal. Dr. Jayarajan is the palliative care consultant at PD Hinduja Hospital, Mumbai. And Dr. Prakash Fernandes is the head palliative partnership, Cipla Foundation, Mumbai. The points we would like to discuss is palliative care services in India. What are the ground realities? What are the challenges in its implementation? Where are we now and how can we improve it? Can I have the next slide, please? So I think this question I would like to, is the third panelist there? Is there?
Yes, Dr. Patel.
Dr. Fernandes. So I would like to address this to you as to what percentage of cancer patients in India require palliative care and how many have access to it.
Yeah, thank you, Dr. Firuza, for that question. And I think it's really good to begin this because it really depends on how we look at palliative care and our definition of the scope of palliative care. And I think if we look at two aspects of palliative care, one is that palliative care is focused on how the disease is impacting the individual, on their pain, on their symptoms, how they're dealing with this diagnosis that they've just received, how it's impacting them spiritually, financially, and the caregiver. So that's one aspect of palliative care. The second, if we look at palliative care as looking ahead and preparing the patient and family for what's going to happen, perhaps, the changes that they need in their diet, the physiotherapy, the kind of precautions they can take as their symptoms go on. So preparing them for that journey, which is really important because that helps adherence to treatment. So if we look at these key aspects of palliative care, then I think every patient who's diagnosed with cancer requires palliative care, right from diagnosis. And as you mentioned, given that a vast majority are presenting at the advanced stage, makes it all the more important in India. So I think if we have an incidence of 1.4 million and the prevalence of about 2.7 million, everybody requires palliative care right from diagnosis. In terms of how many people get access to it, there is not so much data available in India. But if we look at morphine as a proxy indicator, and we look at the recent Lancet Commission report who did on kind of pain relief, it found that only about 4% of those with any serious illness who required pain relief had access to palliative care. So the vast majority, 96%, we're saying, perhaps are people living in pain and suffering because of that pain. And I think that the Lancet Commission really aptly called, we've got a huge call actually for action to really reduce this abyss in creating access to palliative care.
So yes, we all agree, I think, that palliative care access is very limited to patients in India. So the next question I would like to ask Dr. Navin is, how many palliative care specialists are trained in India every year? And how does this compare with the number of trained oncologists per year?
Thank you, madam. Good evening.
Good evening.
in 2012 is I'm talking about two levels of training. One is the more generalist training and the specialist training. I'll start with the specialist training. In 2012 was the first MD program started at Tata Memorial. And from 2012, if we take a decade now, that is till 22, 23, now we have 5 places where there is an MD palliative medicine offered and 5 places where there's a DNB palliative medicine offered. And if you cumulatively take the number of training positions every year, it is around 26 training positions every year. But if you compare to that of a number of oncologists training, it is probably very, very less. So it is not in proportion to that. Whereas if we look at in any of the high-income countries, the palliative care training is almost 2/3 of the medical oncology training. So that's the gap with respect to the specialist training. With regards to generalist training, you are part of the Indian Association of Palliative Care, and from 2007 onwards, there has been a certificate course of palliative care, which now around 4,000 people in India have undertaken that certificate course. But these are very short training program. And in 2016, we have started a program called CTC program, that is Cancer Treatment Center Training Program, through All India Institute of Medical Sciences with the funding from Lian Foundation, that is Asia Pacific Hospice Network. And we have last data that I looked up from 2016 to now, we have set up palliative care OPDs and centers in 46 centers, 46 cancer centers. So they may not be necessarily specialists, but they are probably they're doing some other thing, like they may be doing anesthesia or oncology, but they have been upskilled to provide palliative care.
Yes, I think this is the main thing that we have in India, isn't we have specialist trained palliative care people much less than other general palliative care being done either by pain anesthetists or by radiation oncologists or something. So yes, trained palliative care physicians are grossly inadequate, and I think we need to address this at some stage.
Yes.
So, Dr. Jayarajan, I'll come to the next question, and that is that how many palliative care services, as we know that the IAPC has formulated that we have that manual for what should be essential services, and we have desirable and essential in this group. And in the essential part that a palliative care facility must have, we have that they should have trained doctors, they should have morphine, and they should be documenting the things well. So how do you feel? How many palliative care services always have a trained doctor, proper documentation, and uninterrupted supply of oral morphine in India?
As far as, are you able to hear me? Thank you for the question.
Yes, sir.
Sorry?
Yes. As far as the three parts of the question, as far as IAPC standards were concerned, there were supposed to be essential services as well as desirable services.
That's right.
So what happened was that there was one survey, actually I looked for it, and there was one survey which was done in 2019 between the first half, and I'll be quoting most of the figures from there only. It was found that some 250 organizations entered into were invited to be part of the study, and only around 23 centers participated in the study. And one of the questions was that assessment and documentation of pain and pain scale. This study actually revealed glaring deficiencies in the part of, as far as the essential services and the desirable services are concerned. As far as documentation and assessment were concerned, found that around less than 6% actually assessed and documented pain and according to the pain scale all the time. Around 4.5% of the respondents never even documented this, and 89.2% actually sometimes assessed and documented the pain according to pain scale and used pain scale. As far as other symptoms are concerned, only 4.9% actually of 227 respondents actually said they always documented and assessed other symptoms, while 89.7% said that they assessed it sometime, and 2.7% never did it, and only 1.3% said often. Although we believe that there will be uninterrupted supply of morphine in most palliative care centers, the study revealed that only 5.4% of the organizations were able to give uninterrupted supply always. 84.7% were able to do only sometime, and 4.9% were never able to do that. So this showed that assessment as well as supply of morphine is concerned, there were good amount of deficiencies. As trained doctors were concerned, the standard set was actually 10 days of clinical care, palliative care training under supervision. The study revealed that as far as the availability of trained doctor as per the standards of IPC was concerned, only 5.4% of the respondents had trained doctor available for patient services all the time. 85.2% said sometime, 4% often, and 0.9%, 1% of them said that they never had a trained doctor at any time for delivering palliative care services. So the report has revealed that this was in 2019. The report has revealed in which 26.4% were government-run organizations, and remaining were NGOs and few private hospitals and community-led initiatives and hospitals. And it showed that although IAPC standards have been set for essential and desirable services, the report shows that even in 2019, there were glaring deficiencies.
The reason I asked this question was when we normally just ask for a tick mark, do you have morphine? Do you have a trained manpower? This usually comes out as yes. However, if you see the detailed report,
yes,
only 5.8% had continuous morphine,
yes,
which is very sad, because I think to start somebody on morphine and then not to be able to give it to them is a crime after that. Similar with the doctors. So that is why I put this as saying that just that tick mark that so many percent have morphine is not enough.
Yes, absolutely right.
People is not enough. Dr. Navin, the next question I'll ask you, and that is that are most of the palliative care services set up in the government hospitals or basically run by NGOs or private hospitals these days?
Yes. So initially, if we look historically in the last 3 decades, I feel that in the last 2 decades, the first 2 decades, I feel that it was mainly in the government hospitals and predominantly run by NGOs, and very less and less private enterprises taking up palliative care. But there is a good shift in the last decade where I've seen several private cancer hospitals asking for palliative care consultants, setting up palliative care department. Many private medical colleges setting up palliative care services. Now, if we just look at the DNB, 5 DNBs that has been started, all are in private institute, some in corporate hospital. Now, if you look among the 5 MDs that are started, 3 are in government and 2 are in private. So there is this change in trend, and people are realizing more and more because patients and families are asking for it. They're asking for a good quality of life, good symptom relief, even during treatment and beyond that. So that felt need is there, and I'm just looking at the question below, which links to the above question.
Yes, I think so. You can answer that as well.
Yes.
It's the same thing, Do private hospitals invest? Because
yes.
our impression always has been that it is something that needs to be provided free to the people and that everyone should have access to it. So therefore, my question was that do private hospitals also invest in
Yes, madam. Yeah.
Answer that partly, if you want to continue.
Yeah. Right now, I am in a private medical college.
Yes.
And there is significant investment in palliative care. We are now 4 consultants, although we have an MD program. And you know, always the return on investment need not be financial. You know, there has to be a value-based return. And what they have felt is that there is significant cost-saving benefit also. We work very closely in ICUs. And one thing that we have done is that the average length of stay after palliative care has come in has dropped from 15.9 days to 9.1 days. Now, this is a huge indirect revenue, you know. So that's why they need a robust palliative care service to be there. So they are investing. But Jayarajan would agree with me. Any private enterprises that invest money would always look at the outcomes, and outcomes are not just financial outcomes in terms of family satisfaction, goodwill generation, and all those things are also outcomes that would be looked at.
Thank you. Can we go to the next slide, please? Now, this was again to Dr. Navin, or to that what are the main challenges faced in setting up a palliative care service, and how is it different in a government setup or in a private setup? Dr. Navin, or hello? Hello? Can you hear me?
Yeah, we can hear you, ma'am. Dr. Navin, can you hear her?
Dr. Navin, or anybody else who wants to answer this?
Dr. Fernandes, do you want me to answer, or would you like to?
Anyone who wants. I can only see you, Dr. Navin and Dr.
I'm there.
Yeah, okay.
Okay. Any one of you who wants to.
Dr. Navin?
Yeah, so challenges faced in setting up a palliative care service. If you look at, again, it depends upon whether we are setting up a specialist service or a service in a secondary hospital. In a specialist service, the big challenge that we have is availability of consultants. You know, most of the palliative care services are looking at MD completed. And I know that at this point of time, there are at least 10 hospitals where there are vacancies. So one of the important challenge is availability of trained human resources. Alongside, in some places, there would be challenges related to opioid access, and institution-related challenges most often are purely a lack of understanding about the scope of service or the benefit it can. So I hear some places where they say that their institution are not starting because they don't think it's important. But it's purely because of lack of understanding. But I feel two important challenges is the trained human resources, and at some places, access to medications.
Okay. So, Dr. Prakash, at what stage in the trajectory of the patient's cancer are most patients referred for palliative care?
Yeah, I think given that the perception of palliative care is towards end of life, I think most of the referrals do come in at an advanced stage. However, over the last 5 or 6 years at our CIPLA Palliative Care and Training Center, we have noticed a change in trend. So while initially we had about 80% being referred at really end of life, today that's fallen to about 60%. So about 40% of patients are coming in a bit earlier in their disease trajectory, even concurrent with chemotherapy. Between cycles, they're able to come into the center, get a care plan. And therefore, I think there is now a changing perception that palliative care can start a bit earlier. And I think that's the model that we found is really working as well when it is integrated into a hospital setting. And therefore, it's not really looked at as a referral in that sense. It's looked at as joint working in a sense of a team who is supporting that patient. And I think that really is therefore kind of a move which we need to work towards, therefore, that it's looked at as joint care, shared care, with palliative care professionals adding in as early as possible.
Okay, I think we'll skip a few questions. One of the ones that I want to ask is that, is palliative care covered under Ayushman Bharat scheme? And also, does medical insurance cover it? Anyone wants to take that up?
Yeah. So, madam, with regards to medical insurance, now in this hospital which I am there, it's a private medical college, and most of my patients are insured. No insurance has been ever denied. And if you are, rather than calling it palliative, if you clearly tell what you are trying to do with the patient, most of the time there's no denial. Now, Ayushman Bharat scheme, the new packages are ready actually. So there was a panel that was created to create Ayushman Bharat packages for palliative care. And these packages are quite good and quite competitively priced. I think there are some forms of approvals that are needed, and I think it should be released shortly in next few months.
Okay. So, Dr. Jayarajan, I would like to ask you, can we have the next slide, please? Do you have any regulatory problems in storing morphine or getting continuous supply of morphine? And what are the main hassles you'll face in getting morphine?
I don't face any hassles in getting morphine because it's in a hospital setup. So oral morphine, injection morphine, as well as fentanyl, most of them are available easily.
So none of you, sorry.
Yeah, so at this moment, as far as our institution is concerned, I don't face any problems getting oral morphine or fentanyl patches or buprenorphine patches.
I'm asking this question mainly for people who are in the government hospitals or even to that with the introduction of the fentanyl patch, has the need for oral morphine decreased? Because it's easier in our setup over here, at least in our area, for people to access and get fentanyl than get oral morphine. So is this something that the others also have faced?
We have patients on fentanyl patches. The issue is not that oral morphine, the need for oral morphine is decreased. As far as I'm concerned, I go with the WHO analgesic ladder and we use morphine as the first line. But the problem is that most of when patients are referred to us, there might be patients who have been started on fentanyl patch rather than oral morphine. And then switching back or changing is near impossible because if they have good control, our etiquettes and ethics do not allow us to switch to oral morphine, basically.
Yeah, I agree with Dr. Jayarajan. Yeah, I feel, I do not want to generalize this. Oncologists sometimes feel more safer to use fentanyl patch than oral morphine, and it's okay. But again, it depends upon who is prescribing, and it's lot prescriber driven. We never felt that we use fentanyl patches quite a bit. Our consumption, if you take national standards, we are using quite a bit of fentanyl patch, but still our oral morphine exceeds that of fentanyl patch, and we are using it as indicated by the book. Yeah.
The reason I asked this question was that most of us as palliative care doctors would use oral morphine. But a large number of us in our practice, we have seen that the oncologists have started using it and they start using fentanyl straight away because they find that easier to obtain probably.
But it's also marketed more, madam.
Yes, probably.
That's the problem. That's the one.
Yeah. Can we have the next slide, please? I think we are short of time, so I will just ask one or two questions from this. One is that, do you feel that one of the main reasons palliative care has not been able to make its mark is because we have mainly focused only on cancer? Just a short answer from anyone.
So I don't think really, maybe it is not the main reason. I feel if
I said one of the main reasons.
Yes. I know if palliative care in cancer had shown it could get integrated early on, perhaps it could have been the example for other serious illnesses. I think kind of the main why it's not made its mark is because it's looked at as end-of-life care, and the culture of multidisciplinary working is not really kind of part of the Indian culture of working. And I think if there's a multidisciplinary culture, if people are willing to share kind of caseload, share the stress, and look at palliative care as being from diagnosis, I think we can go a long way for palliative care to really transform the healthcare system.
So the last question I'd ask is that, do any of you feel that by changing the name of and the definition of palliative care to something that looks after suffering as a whole and symptom management also would benefit palliative care?
Internationally, there are studies to support this view. And I also conducted a PhD level research in my place. It was with the pediatric oncologists, and a lot of pediatric oncologists did feel that we should change the name. However, that said, changing the name, we have already changed from hospice care to palliative care. And in the United States, they already changed to supportive care. And from supportive care, now they're going to call it as quality of life services. You know, unless we change the way we practice or way we project ourselves, just the name changing might not suffice.
Oh,
I totally agree with it.
Yeah.
okay. So I think we are running short of time, and I'd like to thank all the panelists for being there and the organizers for giving us this opportunity. Thank you very much. Back to
Thank you, ma'am.
Thank you, everybody.
Thank you so much, ma'am. And I don't think that anybody would have covered it. I mean, such a big topic in such a small time. Though palliative care is such a topic that we can discuss all day about it.